talking about reinventing an industry, and one of the big innovations in how healthcare services are delivered has been convenient care clinics. I was reading that apparently in 2009, which is of course 4 years ago, 1/3 of Americans lived within a 10-minute drive of a convenient care center. In 2010, patients visiting retail clinics reported that they chose to do so because they couldn't get an appointment at their primary care providers, at their doctors. Otherwise, roughly 1/4 of them, if they couldn't go to a convenient care center, would have gone to the ER. So what we're talking about is ultimately the way that these retail clinics are filling a gap. And obviously, Take Care Walgreens is one of the major players in this. Can you tell us, Alan, how are the clinics doing? What have been some of the successes or the challenges that you all have experienced?
Yes, we're undergoing incredible growth and interest right now. I think when the industry started 7 or 8 years ago as a convenience and a consumer demand sort of focus, that was the original model. Today, what we're seeing is the potential for population health management and relevance in the health system from the hospitals, physicians, health plans that are showing great interest in what we're doing. So we're evolving our model from acute episodic care, convenience for simple things, to a much more complex type of care that still is relevant and still is possible in a retail clinic setting, but in partnership with health systems and physicians, and focusing on the strength of our locations, our nurse practitioners, and the ever-growing role of the pharmacist in helping with health and wellness.
So how does chronic care, I know you all have been doing some things to kind of expand the offering to include chronic care and helping treat chronic conditions. Can you talk about what you all are doing there, and particularly what you just mentioned around that kind of the interrelationships with other providers within a given patient's sort of life, if you will. Can you talk about that continuity of care and how that is actually working in practical terms?
Yes, I think as we see the markets changing and evolving from a fee-for-service mentality, market by market, to more population health, I think Walgreens' strategy has been to think out of the box. What kind of health and wellness services could be offered in these 8,200 very convenient locations? And again, it started with convenient care, simple, acute episodic, and now we think about things like chronic diseases and the patients that are coming into these pharmacies and drugstores 12 times a year, sometimes 48 times a year. What else could we be doing at Walgreens with our clinics, with our pharmacists, to be monitoring those patients, to be intervening in some of their compliance and adherence to medications, to be doing physical exams or checking their vital signs. And we've just scratched the surface, I think, of where that goes. One of your questions was lessons learned, some of the positives and negatives. I think years ago, the physician community was largely threatened by convenient care, suspicious of it, and not supportive. And I wouldn't say there's been a wholesale change, but what we see market by market now is a greater understanding of the potential for a role as a population health manager. And what's very unusual, I think, is thinking about healthcare being delivered in locations that were prime real estate for consumers, located where they live and work and play and shop. And as partners with physicians, we've really developed this concept of what else can we do in chronic disease management. These are convenient locations, free parking, in and out. We see appointments and walk-ins. Aren't there things we can do in the clinics, which are open 80 hours a week, that the doctors can't get to and that are not necessarily emergencies? And that's where we see big potential for growth.
Ben, at the Christensen Institute, I know you all have thought a lot about retail clinics. Can you talk a bit about how retail medicine and this sort of convenient care clinic model is perhaps a better way of sort of matching supply with demand? Is this, to use Clayton Christensen's terminology, is this a disruptive innovation?
We believe it is. If you think about the anatomy of a disruptive innovation, you can simplify it to two parts. One is a simplifying technology that allows people to do things that were once available only to highly skilled and wealthy people, and then becomes available to less skilled, less wealthy people. And the analog that Professor Christensen often uses is in computing, where mainframes were $1 million pieces of equipment that filled a whole room and could only be operated by a highly trained person. And now we have smartphones in the palms of our hand that cost a couple $100 and can be operated by any regular Joe. We think that the fundamental simplifying technology in a retail clinic is the concept of precision medicine. And this is conditions that are reliably and precisely diagnosable and treatable. And it began, as Alan mentioned, with a limited menu of conditions in retail clinics that fit this criteria. Now, the simplifying technology is just one part of the anatomy of a disruption. The second part is that the simplifying technology has to be nested in an innovative business model. And the technology is usually the easier part. The harder part is the business model. Mm-hmm. And successful disruptive innovations usually target the least attractive customers in a market, or people that don't consume at all in a market. And again, retail medicine hits this criteria, where they're often targeting people who don't have a primary care physician, or who have one but can't consume from them because of confounding convenience factors. So in terms of, is retail medicine disruptive, we think yes. Now, typical disruptive innovations begin with a simplifying technology and an innovative business model at the low end of a market, and tend to systematically move up market into more sophisticated and complex things. Walgreens' move, since we were talking about Walgreens, into chronic care management might be an example of moving up market, but only if it's consistent with the simplifying technology and the business model that is advantaged. Companies often make the mistake of getting in at the low end and then thinking, okay, now we have to go steal our incumbent competitors' best customers. And they do so by trying to replicate the cost structure of their incumbent competitors, and they almost always get killed. So I think the really interesting question about retail medicine and whether it can systematically move up market here is, do they have the right business model and the simplifying technology to genuinely compete with large incumbent health systems, or complement large incumbent health systems in a way that there won't be win-lose dynamics that will just crush the retail.
And so, Alan, what's your response to that? I mean, do you see that there is the opportunity for Walgreens to do that sort of a moving up, the enabling business model, the enabling technologies that we've just been hearing about?
So yes, the answer is yes. For us, it wasn't an abrupt look at where can we move up on the chain. It was a natural evolution of the practice. So the patients that we were turning away for the last few years were hypertensive, diabetic, obese patients whose flu shots and physicals and sore throats we took care of, but the more important health needs they had, which are practitioners at the top level of their license, are absolutely trained to provide that care, we were turning that care away. So this was a natural evolution. It took a long time to develop the protocols and guidelines and the physician oversight. What I think is exciting is, instead of competing for those chronic disease patients, in every market we're in, we're being asked to join the clinically integrated networks that are evolving from the health systems with the help of the health plans, and to become an integrated part of these delivery systems instead of a competitive ancillary option for patients.
So Ben, what else? So we're again talking about this reinvention of an industry. What other kinds of, beyond this corner store care opportunity, do you see other types of new technologies or new business models that could be coming, that might be similarly disruptive, that would be a part of this reinvention?
Absolutely. You know, we simplistically think of healthcare in a jobs to be done perspective. What jobs are patients trying to get done in their lives for which they hire the healthcare system? And we think, again, very simplistically, there are three. There's the job of, I think something's wrong, I need to figure out what's wrong, diagnostic job, right? There's the job of, I know something's wrong and I need someone to fix me. That's a treatment or therapy job. And then there's a keep me well job, which we usually forget about in most of our lives. If you think about the healthcare market in terms of serving those three jobs, right now people usually only get paid in the healthcare system for serving the second one, treatment. There are new technologies coming, one like Theranos for a point-of-care diagnostic system, or there's a multitude of health tech startups, that I won't go through the litany of them, who are enabling stakeholders like employers and even patients to evaluate quality and price for the specific diagnostic job that they're trying to get done, independent of treatment. So I think we'll see in the future a fragmenting of these three jobs into independent business models, whereas currently in the healthcare system, they're predominantly bundled into the business model of whoever can get paid for treatment.
So Barbara, this leads nicely into, I think, into what you've been doing at the Mayo Clinic. So I know you've been doing a lot of thinking about redefining the traditional care environment. So, you know, if retail clinics are one disruption and one way of redefining, can you tell us about some of the other sorts of projects that you've been working on and other sorts of things that you see coming?
Certainly. So a good place for me to start is just articulating the primary value of Mayo Clinic, and that's that the needs of the patient come first. In fact, we're just celebrating our sesquicentennial, so just into our 150th year as an organization. And that's really been the core value that has sustained us and will continue to. And it's really around this idea of the needs of the patient. And we really stepped up our commitment 5 years ago when we opened our Center for Innovation. That exists to transform the delivery and experience of health and healthcare. And a lot of thinking, as the other speakers are mentioning, around how do we think about the shifts that Mayo will continue to be there for patients who need healthcare. So what about the diagnostics? What about the treatment? Of course we'll be there. But increasingly, you know, we see ourselves in the knowledge to delivery business. And this opportunity to think about extending the model to care for people and patients where they are, really connecting with people where they are, is very much of a premise of the work that's going on in the Center for Innovation. A couple other comments. We've been building a very diverse group. We now have a team of almost 70 people, and it's really around thinking differently. So we've brought designers and anthropologists and physicians and really trying to mix up the idea of design thinking, trying to deeply understand user needs of our patients and people to then drive the models and the services that we're building out. So we really don't start with sort of a shiny technology or completely understanding the business model. We really try to have faith in the process that as we iterate and co-create the models with the patients and people we're trying to serve, that we'll get there through the process and the methodology. So to answer your question more specifically, we have platforms and we have project portfolios. We're working in innovation and care delivery transformation around the Mayo practice, how to make the Mayo model, you know, more effective and efficient for all the reasons we've been talking about today. Connected care, how do we connect our care to people and patients where they are? Health and well-being, increasingly around how do we move into the space of helping people optimize their health? And then our fourth platform is around the Innovation Accelerator. That's a lot about the conditions for innovation across the organization, ideation, and trying to scale to implemented solutions. So I would say in the projects I shared, the commonality is really this idea of shifting the center of gravity away from the physician and the physician's office to the person and people where they live. So this idea of retail, of mobile, bring it on, we're all in. Because how do we preserve the Mayo model, the tertiary kind of facilities and care for patients who most need that? And how can we connect our networks and the kinds of collaboration that Alan's describing to create more of that ecosystem?
And so what do you do, I mean, beyond the Mayo Clinic, do you do things to share these ideas with other care providers? What kinds of things do you do to kind of see them working in the wider environment?
So we're doing a lot of work, and a lot of it is just really the essence of how the model works. So the partnering strategies are very, very important. If I respond with an example, for example, we're working on something called Healthy Aging Independent Living. It's the idea of trying to help seniors age or thrive in place. So there we actually have been building a consortium model of like-minded organizations that come together around that pursuit. So we have groups like United Healthcare, Best Buy, and others that are part of trying to determine what are the experiments that we should be investing in and the insights we're generating, so we can go ahead then and build out the products and services either together or accelerate it through their own companies and development. So there are a lot of ways that we try, even in the beginning with partnering strategies, to co-create the ideas going forward and then connect and scale more broadly.
Mm-hmm. Mm-hmm. So let's talk a bit about mobility. Obviously everyone's got a mobile phone, their tablets, there are the wearable technologies that monitor your physical activities or your vital signs. How are you all doing things, Alan, at Walgreens with mobility? And I think maybe also for you and Barbara, how have you thought about, at Mayo Clinic, how have you all thought about mobility as fitting within kind of this wider provision of the boundaries of care, and expansion of the boundaries of care? So maybe we'll start with you, Alan.
So I think mobility and healthcare is a natural evolution beyond just retail clinics. What we hear from patients every day, consumers, we survey them widely, they want care where they want it, when and how, more so than ever before. And as healthcare providers, we need to listen to that. We've historically, the healthcare system is very heavily capital asset based, and we will build it, and they will come to us no matter where they have to park or how many days off of work they have to take or the kids out of school. So I think our retail clinics began this movement away from traditional asset-based, where is it convenient for the patient, and mobile goes one step further. We now enable on a smartphone the surveying of where we have clinics, where we have open appointments, and we've piloted with iTriage to actually make the appointments on a phone. Mm-hmm. We have a lot of health systems coming to us and asking, and payers. Walgreens stores are everywhere. They're in the rural parts of America where it's very hard to get primary care. Couldn't Skyping or FaceTime or a simple iPad with specialists, nurse practitioners, other providers back in a major metropolitan area, couldn't we use a Walgreens store where patients are coming for their prescriptions anyway to deliver some health and wellness and education services, and maybe even screenings and exams? We're looking at all of those things.
Barbara?
Yes, absolutely. We see mobility as the future, and what we're trying to do, as mentioned about the methodology, is really learn from patients and people that we're trying to serve. To the point that Charlotte made this morning about the burden of chronic diseases, we've started with things like asthma. How do we connect with adolescents who have asthma, where what they don't want to do is be coming in to see the specialist in the office practice? So how can we help them use their smartphone to connect to the care team, to be texting their nurses and care providers to know if they're in or out of control with their asthma? We're working on a big project in diabetes. How can I not be labeled as a patient who's sick with diabetes? I'm just a person who needs to live with this thing called diabetes, and how can it integrate into my life? So really trying to use our user-centered, human-centered approach to build out these new kinds of models.
I'll add something, and it's, if I harken back to what I said before about those 3 patient jobs, you know, something's wrong, fix me and keep me well. We really think that mobility is going to unlock the opportunity for people to make money just focused on the diagnostic job, tell me what's wrong, or the job of keep me well. Whereas now, because of the scarcity of clinical talent and having to be in the physical presence of it, pre-mobility, the business model lent itself to paying only for therapies, and you bundled everything else in. We think mobility is going to unlock that, and people will be able to build businesses where they can make money just on tell me what's wrong, or just on keep me well. And we think that'll be a huge benefit from a cost and outcomes perspective as well over the long term.
Okay, great. So we can take some questions. I don't know if there are people who have some questions they've been holding on to.
It's hard to see.
I see somebody here, sort of in the center. Please identify yourself so we know where what your perspective comes from.
Hi, I'm Lynn Wyatrowski, Bank of America, Merrill Lynch. This probably applies to Alan and to Barbara the most, but as 2 very large employers, what are you doing on the health benefits side to kind of inspire the progression of your employees and thinking about all the innovation that can be out there?
That's a great question. We, first of all, Walgreens made the decision a few months ago, somewhat of a surprise to almost all of the employees, and created an exchange for this year's January enrollment. And so I have a couple of weeks left to make my final choices. There are many more choices for medical, dental, and vision, and all sorts of opportunities to cost share. And it's very interesting. It's forcing, we have about 250,000 employees, and it's forcing all of us to learn about the exchanges and to pick healthcare models that make sense for our families. A lot of incentives around wellness and prevention. So I'd answer it that way, in addition to just all sorts of pilots going on around the country around the same thing, health and wellness. Theranos, which Ben mentioned, is a great new technology Walgreens has partnered with. Finger stick technology for what used to be only a venipuncture, a lab draw, a big tube of blood. 97% or so of the lab tests that are ordered by doctors can now be done by this technology with a little micro tube of blood and a finger stick at a Walgreens store. That's a disruptive change in the way we deliver care.
I just tag on to that. A lot of things going on at Mayo Clinic around promoting, health and well-being and all kinds of things with our employees. We really like the idea of labs and prototypes and ways that we can test out our new care models. So we have labs where we co-create these models with patients. We also, of course, go with our patients and people to places like their homes to do the ethnography and the observation. But with our 60,000 employees, and given that we're self-insured, it becomes a great way for us to be testing these models. So for example, we built out something like an e-consult. So we've defined e-consults for 170 medical conditions that our own physicians have said we really don't need patients, people, employees to come into the specialty practice to see us for these kinds of conditions. So for our employees and dependents, the specialty, the e-consult, e-specialty consult is free. But as we're building out those models in this co-creation kind of context, it's really trying to keep iterating on the model to keep make it better. With our diabetes work that we're launching now, it's really working with our employees and dependents to try to, again, use these as labs and groups to learn from, to iterate, and to build out a better model. So great question.
More questions?
Thanks. I'm Deborah McConkey with Bottom Line Healthcare Marketing, and I've been interested in certainly how to involve patients as customers. So to ask Alan in terms of for the future, do you plan on incorporating, let's say, alternative things for wellness? Those could be supplements, things like nutrition, which is a key part, or even behavioral things like treating depression. So I'd like you to comment on that, and also to speak a little bit about the payment model, because for many of these things, if you're going to reach the consumer where they are, they have their own issues of getting things paid by insurance, what are they going to pay for, and all of that. So how do you plan to intervene in sort of being an advocate for that, as well as what additional services might you offer?
So the additional services we focus on quite a bit at Walgreens. One of the things we're piloting, as Mayo just said they pilot, for our employees and for consumers, several hundred stores now of the 8,000 have moved the pharmacist out from behind the counter to a very relevant position right in front with a desk, a privacy room, and computer screens. So the pharmacist is no longer in the back filling the prescriptions by themselves. Pharmacy techs are doing that. They're available to counsel patients, with the focus being adherence, compliance, and the whole medical cost of poor use or inappropriate use of medications. In addition to that, I think we have now 17 specialty pharmacy centers of excellence, where one is HIV, that's probably the biggest. We're building cystic fibrosis, multiple sclerosis, transplant. And these are Walgreens stores where the pharmacists are specially trained in the outpatient management of these diseases, the complications from the medications, and the availability of those medications 24/7, 365 days a year. So 17 specialty centers of excellence. On the payment side, I think as we move more toward population management, this all gets easier. Ben's remarks now twice about the three kind of pillars of what patients seek, that prevention and wellness, which hasn't been reimbursed. If you think about global cap or different ways of incenting the providers of care to keep people healthy and happy and less costly, prevention and wellness start to become very relevant. So again, we're intrigued by how many times our consumers and the patients in the health systems we're partnering with walk into our stores where we can make an impact. And I think we're going to see a much different landscape, a much different look of the Walgreens stores and the services being delivered a year from now, 3 years from now, 5 years from now.
In terms of the question about supplements and things about behavioral change, I don't know, it could be smoking cessation or something like that, are you constrained in terms of what sorts of things you can offer in a suite of services through the Walgreens centers? I mean, can you provide sort of a turnkey, better health kind of package to someone that, of course, pulls in products off your shelves? Or is that part of the opportunity, or are you your hands tied?
So, good question. Everything we do extra in the health and wellness space in a store, if it takes up space, physical space, there is a trade-off to what is there today and what are we selling as a retailer today versus the service we're offering. But as health and wellness becomes more relevant, there isn't a day that goes by where someone isn't coming to us with an interesting idea to perform this or that service within our clinics or pharmacies. The decisions around that have to do with, first and foremost, what's right for the patient, what's safe, what's reasonable to do in a retail setting. Are we going to do minor surgeries? No. You can't believe some of the proposals we get. But what's reasonable? And what's relevant and works with the physicians and the existing health systems. We do have to be paid, so there are certain contractual restrictions. But I'm very bullish about the future because those constraints go away to a large degree. under a population management, reimbursement, and delivery model where we're incented to do all of the right things, and the physicians having us touch the patients more often benefit from that, as well as certainly the patients do.
Ben, I want to ask you, will all retailers, you know, all pharmacy retailers, are we going to be seeing this become sort of the de facto model?
Great question. The opportunity and the upside for retail clinic utilization and growth is still huge, right? The study came out last week, says just over 1% of Americans have used a retail clinic.
Wow.
Right? So lots of headroom there. And clearly the retailers have a facility footprint that's close to people and gives them a chance to get into that market. Alan alluded to this in his comment just now, that the challenge is companies almost never can successfully disrupt themselves. And the reason is, especially for a public company, you're trading retail floor space that's generating X dollars of sales per square foot for initially a capital outlay and at beginning at least $0 per square foot. So how do you justify that under your retail business model, and for how long can you defend it before the ready, reliable sales per square foot drumbeat begins in your business model? So I think companies that have appropriate levels of autonomy within their corporations to pursue a retail healthcare business unconstrained will be more successful than those who say, oh, we'll just wrap it in with the retail and pharmacy P&L. But it will be a tension for everyone that tries to get into this space, and it won't be easy.
I know that, I mean, I don't expect Alan to want to get into this, but I do know that Walmart's foray into this has been described as sort of a trial and failure. Why?
I don't think this is simply a matter of renting out space within a store, a retail setting, for something that may logically expand the service. If you don't make a commitment to health and wellness and relevance in the delivery model we have today. So
to be clear, Walmart was renting out space to individual care providers as against what you all are doing.
Yes.
Quite a different approach.
And I don't want to be critical, but it isn't our model.
Yeah.
We have made a conscious decision, albeit the tensions Ben talks about. Sounds like you've been at some of our executive committee meetings. It's a very real tension, but with 8,200 stores, and again, some of the big box retailers will never have that many stores on the relevant corners where so many patients find it convenient. It's a slightly different proposition. Where we fit in health and wellness is a very different proposition, but it comes from leadership and resolve and commitment to a vision. I think you're right, and I think that's what we've done. We've said health and wellness is going to differentiate us. We will be the destination for health and wellness, and we're not doing it again in competition with the existing healthcare system. We're looking to strategically partner, and deliver care closer where the patients seem to want those services.
Okay. Did you want to add to that?
Yeah, sure. I think Alan's exactly right. Leadership, vision, resolve, and I'd also reinforce the appropriate level of autonomy within the corporation. When incremental revenue is generated, lots of hands will raise to claim responsibility for it. When incremental cost is driven, it will usually be pinned on one entity.
I think even some of our executive meetings too.
And so you have to be able to have the right level of autonomy with the right level of resolve and vision to be able to survive those dynamics, especially in a publicly traded corporation.
Yeah. Are there other questions? There's a few gentlemen over here.
Thanks. This is slightly different, and it's focused at Ben. My name's Tom Sattler from Mastery. If you look at the inability of an organization to change, you actually have to look at the whole ecostructure. And I think of the suppliers for this, specifically medical schools. Having talked to recent graduates, one dual doc family, he and his wife are graduating, getting through their residency with a mere $1 million in loans. How do you see the training background to this really changing in a way to lower their cost structure to enable this to happen?
Excellent question. I'll confess I'm not a clinician, so I haven't been through that experience, but you hit on a really significant point. The way we train doctors right now in the United States isn't substantially different from the way it was done 100 years ago in terms of the method. The costs have escalated, as you rightly point out, as the cost of healthcare has escalated in the country. And so the question is, how do we change the training model without disincentivizing people to go into the profession? A couple, I don't claim to have the answer in a neat box, but a couple thoughts. One is that the current training model encourages everyone to experience everything, at least in medical school and residency. And as conditions become more precisely diagnosed and more precisely treated, and business models exist where you can get lots of reps with those specific conditions or treatments, or simulation technology exists that can get you lots of reps with those therapies and treatments, you can make a case that you could specialize much earlier and much more quickly in your medical training with a model that focused specifically on those families of diseases than is done currently. If we don't figure it out, we'll start to have to just import doctors because the quality of the practice of medicine from a lot of ex-US sources in the Caribbean and India and elsewhere is, from what I understand, at least close to good enough, if not as good, as what we're producing in our medical training facilities in the United States. So it's a problem we have to solve. If we don't, we'll need to be net importers of doctors.
Mm-hmm. Please.
Different question. I'm David York with Navigant. My question is, as changes, transformative changes have been dealt with or not dealt with in the past, one of the secondary barriers is malpractice. So I'm wondering, as care gets decentralized to practitioners and locations where that typically hasn't been a major issue, if that features into your view, and if you think it will soon be discovered.
Well, that's a sort of a loaded question. I think as the conditions get more complicated, as we partner with big name health systems, are we more visible in the healthcare system? Probably yes. And when you're visible, you can be targeted appropriately or inappropriately. I think one of the things that intrigued me about coming on board and taking the position I have is the idea of a replicable, scalable delivery of healthcare across the country. So if you go into one of our clinics in Philadelphia, one in Phoenix, one in Denver, if you close your eyes and didn't know where you were, you'd think you'd be in the same location. Our EMR is the same, the forms, the kiosk where the patient checks in. So we replicate everything. We oversee with physician audits and nurse practitioner peer review. We try to replicate a very good model of care. And I think we do a pretty good job of that. It doesn't mean it can't be done on the physician side, but the physicians are typically more independent. I come from a physician background, a medical group background, and productivity is tracked very carefully in most medical groups. The quality of care delivered, the charting of every case is not typically followed. So I think we're under a lot of scrutiny because we're not physicians in our practice, and we take extra care in making sure we're following evidence-based guidelines. With 1,500 practitioners, things happen. Mistakes are made and things are missed. It's part of healthcare, part of medicine. I think we do a very good job of trying to even that out and improve on an ongoing basis. But we don't do procedures. We don't draw blood. We don't do imaging. It's a limited scope of practice.